You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is the first in a series of episodes about congenital heart disease. We'll focus very much on building a framework to understanding the lay of the land of the many different congenital heart diseases, including how to categorize them by side of the heart, as well as how to categorize them by whether they're cyanotic or not, and what it means to have cyanotic physiology, including Eisenmenger syndrome. We'll go over the epidemiology of all these congenital heart diseases and talk about congenital concepts that are true across conditions, such as the QP and QS ratio. And finally, we'll end with a section on congenital disease associations, so you know the word association between these and other heart diseases and systemic diseases. So let's start off with epidemiology. Tetralogy of Fallot is the most common cyanotic congenital heart disease and the fourth most common congenital heart disease overall, comprising 10% of all congenital heart disease. The second most common cyanotic congenital heart disease is transposition of the great arteries, comprising 5% of all congenital heart disease. The first, second, and third most common congenital heart diseases are non-cyanotic, VSD, ASD, and PDA in that order. Again, VSD, ASD, and PDA in that order are the first, second, and third most common congenital heart diseases, and they are non-cyanotic, except in extreme situations. Truncus arteriosus, tricuspid atresia, and total anomalous pulmonary venous return account for 1 to 2% of all congenital heart diseases. All the congenital heart diseases that begin with T are cyanotic: tetralogy of Fallot, transposition of the great arteries, truncus arteriosus, tricuspid atresia, and total anomalous pulmonary venous return. Let's conceptualize all of these congenital conditions in terms of whether they are left-sided obstructed lesions, right-sided lesions, shunt lesions, or mixed lesions. There's also a few that are coronary or venous anomalies that don't fit into any of the above categories. So let's start with shunt lesions. Shunt lesions involve abnormal connections between the heart chambers or great vessels, allowing blood to flow from the left side of the shunt, so a left to right shunt, or vice versa, like in a right to left shunt. These include atrial septal defect, patent foramen ovale, ventricular septal defect, atrioventricular septal defect, anomalous pulmonary venous connections, and patent ductus arteriosus. Then we have the left-sided obstructive lesions. These are structural abnormalities that obstruct blood flow out of the left side of the heart, potentially leading to left ventricular hypertrophy or failure over time. These include coarctation of the aorta, interruption of the aortic arch, congenital valvular aortic stenosis, supravalvular aortic stenosis, subaortic stenosis, and congenital mitral stenosis, core striatum, and Schoen complex. We have already covered congenital valvular aortic stenosis, supravalvular AS, subaortic stenosis, and congenital mitral stenosis in the valvular disease section in a prior chapter, so those will not be addressed in the congenital chapter. Now, how about right-sided lesions? These involve malformations affecting the right side of the heart, impacting pulmonary blood flow, and these can lead to cyanosis if oxygen is impaired. Right-sided lesions include tetralogy of Fallot, Epstein's anomaly, double-chambered right ventricle, tricuspid hypoplasia, pulmonic hypoplasia, valvular pulmonary stenosis, isolated pulmonary regurgitation after repair of pulmonary stenosis, branch and peripheral pulmonary stenosis, and right ventricle to pulmonary artery conduit. The valvular PS, isolated PR after PS, branch and pulmonary stenosis are already covered in the valve disease section and will not be included in the congenital chapter. Then we have cyanotic congenital heart disease or mixing lesions. In these conditions, the deoxygenated blood mixes with oxygenated blood, leading to cyanosis. These conditions often involve complex malformations of both ventricles or great vessels, and include transposition of the great arteries, truncus arteriosus, single ventricle, hypoplastic and left heart syndrome. And any of these can give you Eisenmenger syndrome. Then we have the miscellaneous category of coronary or venous anomalies. These are anomalies related to coronary arteries or venous return to the heart. It includes persistent left-sided SVC and unroofed coronary sinus, and anomalous coronary arteries. That's already covered in the coronary artery disease chapter and will not be included in this chapter. Another way to look at these is to think of them in terms of whether they are cyanotic or non-cyanotic congenital diseases. The cyanotic congenital heart diseases involve mixing of oxygenated and deoxygenated blood, leading to cyanosis, which is bluish discoloration of the skin due to low oxygen levels. Cyanosis occurs in the T disorders that are unrepaired, so tetralogy of Fallot, TGA, truncus arteriosus, tricuspid atresia, and TAPVR. Tetralogy of Fallot is one of the most common causes of cyanosis in infants involving right to left shunting. Transposition of the great arteries is a serious cyanotic condition where the aorta and pulmonary artery are transposed, causing parallel circulation without mixing of oxygenated and deoxygenated blood. Truncus arteriosus is where there is a single arterial trunk arising from the heart, leading to the mixing of oxygenated and deoxygenated blood. There's tricuspid atresia, and there's total anomalous pulmonary venous connections. This can be cyanotic if it's a complete anomalous pulmonary venous return, or if it's partial, then it's non-cyanotic. Apart from these famous 5 T's, there are several non-T congenital conditions that can cause cyanosis. Epstein's anomaly. While not always cyanotic, it can be associated with cyanosis if there is a significant right to left shunt through an atrial septal defect or patent foramen ovale. Syncope ventricle. Conditions such as hypoplastic left heart syndrome or tricuspid atresia can result in a single functioning ventricle, leading to cyanosis. Hypoplastic left heart syndrome is a severe cyanotic condition where the left side of the heart is underdeveloped, leading to insufficient oxygenation. Eisenmenger syndrome is a late complication of unrepaired shunt lesions where long-standing left-to-right shunts eventually reverse, causing right-to-left shunting and cyanosis. We'll talk about this in detail shortly. The non-cyanotic congenital heart diseases are pretty much everything else. These typically involve left-to-right shunts or obstructive lesions where the oxygen saturation is not initially compromised. In VSD, it is usually non-cyanotic, but it can lead to cyanosis if Eisenmenger syndrome develops later on in life. Atrioventricular septal defect is also typically non-cyanotic, but it can become cyanotic if uncorrected and can lead to Eisenmenger syndrome later on. Patent ductus arteriosus is usually non-cyanotic, although large unrepaired PDAs can lead to Eisenmenger syndrome. So let's hone in on Eisenmenger syndrome's physiology. Eisenmenger is the most advanced form of pulmonary artery hypertension associated with congenital intracardiac and great arterial shunting. It may result from any initial left to right shunt that evolves over time to produce pulmonary vascular remodeling and pulmonary hypertension, which reverses the shunt to right to left. This can occur in ASDs, VSDs, and PDA. It can also occur in any of the T disorders that are unrepaired: tetralogy of Fallot, transposition of great arteries, truncus arteriosus, tricuspid atresia, and total anomalous pulmonary venous return. In Eisenmenger syndrome, the ventricular pressures are equal. There's either a mid-systolic murmur due to dilation of the pulmonary trunk or a holosystolic murmur related to tricuspid valve regurgitation. The S2 will be markedly accentuated and single. Eisenmenger syndrome can have secondary erythrocytosis, thromboembolic events, hyperviscosity syndrome, hypertrophic osteoarthropathy, stroke and brain abscesses, and renal dysfunction. These are the other manifestations, non-cardiac, of Eisenmenger syndrome. Symptoms of hyperviscosity syndrome include headache, dizziness, slow mentation, a sense of dissociation, tinnitus, paresthesia, myalgias, restless legs, and bleeding or stroke. Hyperviscosity syndrome can be precipitated by dehydration due to recent GI illness. How do you manage this? Eisenmenger syndrome patients should be treated with supplemental oxygen if it increases arterial oxygen saturation, pulmonary vasodilator therapy, and iron supplementation if iron deficiency is present. If transferrin saturation is less than 20%, you can consider iron supplementation. Unlike in polycythemia vera, there is no need to give hydroxyurea to Eisenmenger patients. Routine phlebotomy is not indicated in Eisenmenger syndrome because it worsens iron deficiency anemia and stroke. For many years, cerebrovascular complications in patients with Eisenmenger physiology were presumed to be due to erythrocytosis, and phlebotomy was performed routinely to maintain normal or near normal hematocrit levels. However, a large study failed to show a relationship between the hematocrit and stroke risk in cyanotic patients. Rather, atrial fibrillation, systemic hypertension, and microcytosis, which can be worsened by phlebotomy and iron deficiency, are the strongest predictors of stroke in Eisenmenger's patients. Phlebotomy may have a role in treating acute severe symptoms of hyperviscosity, but it is not indicated as a routine procedure and also not indicated for mild symptoms such as headaches, leg cramps, and scotoma, which may be due to iron deficiency rather than hyperviscosity. Before you're allowed to give phlebotomy in Eisenmenger syndrome, you must check that their iron stores are within the reference range and that they are well hydrated with IV crystalloid. As mentioned, phlebotomy can worsen the hyperviscosity syndrome if the patient is iron deficient and that has not been corrected yet. Cyanotic patients need a higher hemoglobin than normal in order to maintain their oxygen delivery equation. Eisenmenger syndrome has both thrombocytopenia and thrombasthemia and abnormal coagulation parameters, so Eisenmenger patients are at risk for both thrombotic events and bleeding events. Systemic anticoagulation and antiplatelet therapies are reserved for specific indications, such as clinically apparent thrombocytosis, AFib, presence of artificial heart valves or conduits. After you confirm that the Eisenmenger syndrome patient has PAH, you can actually give them bosentan. The 2018 Congenital Heart Guidelines say bosentan is beneficial in symptomatic adults with Eisenmenger syndrome with ASD or VSD. That's a Class 1 recommendation. Bosentan is a reasonable therapy to treat symptomatic adults with Eisenmenger syndrome with one of the following: shunts other than ASD-VSD, such as PDA or pulmonary window, or complex congenital heart lesions, or Down syndrome, Class 2A. If no improvement, you can use a PDE5 inhibitor or use both bosentan and a PDE5 inhibitor, such as tadalafil. The 2018 Congenital Heart Guidelines give both of these a Class 2A recommendation. Specifically, they say, in symptomatic adults with Eisenmenger syndrome, bosentan and PDE5 inhibitors are reasonable in combination if symptomatic improvement does not occur with either medication alone. That's a Class 2A recommendation. It is reasonable to use PDE5 inhibitors such as sildenafil or tadalafil to treat symptomatic adults with Eisenmenger syndrome with ASD or VSD or great artery shunt. That's a Class 2A recommendation. Uric acid levels are often elevated in Eisenmenger patients are associated with worse outcomes. Now, we need to be more mindful in caring for cyanosis patients. The 2018 Congenital Heart Guidelines put forth best practices for cyanotic ACHD. For example, they recommend recording clinical oxygen saturation at rest, more than 5 minutes after resting, rather than immediately after effort, for example, immediately after walking into a clinic examination room. Meticulous intravenous care should be used to avoid air or particulate matter, which may include use of air or particulate filters on all intravenous access lines, when feasible, and careful de-airing of all lines. Cerebral imaging for any new headache or neurologic sign to assess for possible cerebral abscess, hemorrhage, or stroke should be considered. They also encourage measurement of serum uric acid and treatment with allopurinol in a patient with a history of gout. Supplemental oxygen as needed for symptom relief can be used, but it's not to a target oxygen saturation level and not if there is no demonstrable symptomatic benefit. So supplemental oxygen is mainly used as needed for symptom relief, not to a particular number in cyanotic patients. Avoidance of or cautious use of therapies that may reduce the patient's hypoxia-mediated drive to ventilation, such as narcotics, or in rare circumstances, excess supplemental oxygen. Anesthesia by providers with expertise in anesthesia for patients with ACHD for any non-cardiac surgery. They also encourage non-estrogen containing birth control for women of childbearing potential. An intrauterine device may be a preferred option. Avoidance of birth control entirely is considered not a safe nor acceptable option. Patients with cyanosis can travel safely on commercial airlines without undue risk. Pre-flight stimulation testing or mandated supplemental oxygen is usually not indicated, although adequate hydration and movement during the flight are appropriate. Measurement of coagulation parameters such as activated partial thromboplastin time, international normalized ratio or thrombin time in a patient with hematocrit of more than 55% requires adjustment of anticoagulant volume in the blood collection valves to account for the reduced plasma volume in the draw. Note, none of these recommendations have a class of recommendation associated with them because it's not a formal guideline. Now, let's talk about congenital concepts across conditions, and by that I mean physiology. A QP to QS ratio more than 2.0 indicates a large left to right shunt that generally requires repair. The QP meaning the flow through the pulmonary system, and the QS meaning the flow through the systemic system. In contrast, a QP to QS ratio of 1.0 to 1.5 at the atrial level or 1.0 to 1.3 at the RV or PA level indicates a small left to right shunt that might evade detection. If the systemic arterial saturation is less than 93% without any other reason, then a right to left shunt should be suspected. A QP to QS ratio of less than 1.0 indicates net right to left shunting. For unidirectional shunts, the magnitude of the shunt can be expressed by the difference QP minus QS. Normally, the oxygen saturation in the IVC is higher than that in the SVC. Mixed venous saturation is usually most accurately determined in the pulmonary artery because complete mixing of venous return has occurred at that level. When assessing a transatrial shunt, you have to determine mixed venous saturation proximal to the shunt instead of relying on a PA sat alone. So you can calculate it using the Flamm formula. Mixed venous oxygen content equals 3 of the SVCO2 content plus 1 of the IVCO2 content all over 4. So you're basically weighting the SVCO2 content 3 times compared to the single weight you're giving to the IVCO2 content. That's why you divide it by 4 after multiplying the first by 3 and the second by 1. If pulmonary artery oxygen saturation exceeds 80% or is 8% higher than the SVC's oxygen saturation, then a left to right shunt should be suspected. During a systematic shunt run, several samples should be taken at each location for O2 saturation measurement and average. An O2 saturation step-up of 8% or more is necessary to diagnose a left-to-right shunt at the atrial level, or 5% or more to diagnose a left-to-right shunt at the level of the right ventricle or pulmonary artery. This is because at baseline in normal hearts, O2 content in different portions of the right atrium may vary by as much as 2%, reflecting the streaming of blood that enters from the SVC, IVC, and coronary sinus. Physiologic shunting refers to shunts that are correctable with administration of 100% oxygen, including hypoventilation, pulmonary edema, and cardiogenic shock. Anatomic shunting refers to shunts that are not correctable with administration of 100% oxygen. Now let's briefly touch upon ECG across congenital conditions. Atrial flutter is much more common than atrial fibrillation in young patients with congenital disease, usually arising from surgical repair. Surgery-associated atrial flutter generally does not respond to pharmacologic agents and usually needs catheter ablation. First-degree AV block is often present in patients with AV septal defects, congenitally corrected transposition of the great arteries, and Epstein's anomaly. If electrocardiographic findings of myocardial infarction are seen in an infant, suspect anomalous origin of a coronary artery. Left ventricular overload due to aortic or mitral regurgitation can cause Q waves that are deep in the left precordial leads. Now, you may hear about different stages, stage A, B, C, and D, when people talk about ACHD, but these are different. They're not the same as the congestive heart failure stages, A, B, C, and D, from the congestive heart failure chapter. Apart from knowing the New York Heart Association functional classes 1 to 4, which is based on the symptoms, you will want to know the ACHD physiological stages, A to D, which correspond somewhat to the New York Heart Association functional classes. So let's start with ACHD physiologic stage A. In stage A, there are no hemodynamic and anatomic sequelae, there are no arrhythmias, there's normal exercise capacity, and normal renal, hepatic, and pulmonary function. In ACHD physiologic stage B, there's mild hemodynamic sequelae, mild aortic enlargement, mild ventricular enlargement, mild ventricular dysfunction. There may be mild valvular disease, and the shunt is trivial or small, not hemodynamically significant. There may be arrhythmia not requiring treatment, and abnormal objective cardiac limitation to exercise. That's ACHD physiologic stage B. How about ACHD's physiologic stage C? Here, there's significant, meaning moderate or greater, valvular dysfunction, moderate aortic enlargement, venous or arterial stenosis, mild or moderate hypoxemia or cyanosis, a hemodynamically significant shunt, arrhythmias controlled with treatment, pulmonary hypertension, less than severe, and end organ dysfunction that's responsive to therapy. How about ACHD physiologic stage D? This is the worst one. Here you have severe aortic enlargement. You may have arrhythmias refractory to treatment, severe hypoxemia, and almost always with cyanosis, severe pulmonary hypertension, possibly Eisenmenger syndrome, and refractory end organ dysfunction. That's ACHD physiologic stage D. Now, let's talk about some high-yield associations, including genetic syndromes with congenital heart associations. Down syndrome, which is trisomy 21, their congenital association are all down the midline. ASD more so than VSD, more so than endocardial cushion defect, which is AV septal defect. Edwards syndrome, which is trisomy 18, is associated with ventricular septal defect, VSD. Holt-Oram syndrome, hand-heart syndrome, which is a mutation in TBX5, is associated with ASD and VSD. 22q11 syndrome is associated with tetralogy of Fallot, truncus arteriosus, and interruption of the aortic arch. Ehlers-Danlos syndrome, a mutation in collagen 3A1, is associated with tetralogy of Fallot, ASD, and mitral valve prolapse. Marfan syndrome, which is a mutation in fibrillin 1, is strongly associated with aortic insufficiency and aortic root dilation. Marfan syndrome accounts for 50% of aortic dissection in less than 40-year-olds. Marfan also has a mitral valve prolapse in 70% of patients, with 1/4 progressing to severe mitral regurgitation. Turner syndrome is mainly associated with bicuspid aortic valve and also coarctation of the aorta. Noonan syndrome is mainly associated with pulmonary cyanosis and also pulmonary valve dysplasia, ASD, and HCM. Williams syndrome is associated with supravalvular aortic stenosis more so than pulmonary artery stenosis, VSD, and ASD. Loeys-Dietz syndrome is associated with diffuse aortic and arterial aneurysms. How about in utero exposures with congenital heart associations? An infant of a diabetic mother may have transposition of the great arteries and also asymmetric septal hypertrophy. The septum along the LV outflow tract, not the RV outflow tract, is hypertrophied, thus decreasing systemic circulation, leading to weak pulses, low blood pressure, prolonged capillary refill, hypoxia, and lactic acidosis. Infant with fetal alcohol syndrome may have VSD, ASD, PDA, or tetralogy of Fallot. An infant with prenatal lithium exposure may have transposition of the great arteries or Epstein's anomaly. How about arrhythmias associated with congenital heart disease? AV septal defects are associated with supraventricular tachycardia and complete heart block. Tetralogy of Fallot is associated with supraventricular tachycardia, ventricular tachycardia, and sudden cardiac death. LTGA is associated with complete heart block. DTGA, status post atrial switch, is associated with sinus node dysfunction, supraventricular tachycardia, and sudden cardiac death. Eisenmenger syndrome is associated with supraventricular tachycardia and sudden cardiac death. Epstein's anomaly is associated with supraventricular tachycardia, atrial fibrillation, and pre-excitation syndrome. Fontan surgery for univentricular heart or hypoplastic left heart is associated with sinus node dysfunction, supraventricular tachycardia, and atrial fibrillation. That's everything for the introductory episode for congenital heart disease. We've gone over epidemiology, a framework, the physiology, conditions that are true across congenital heart disease, Eisenmenger syndrome, cyanosis, and high-yield associations.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.